I'm Kari Breuer, and I'll be presenting on chiropractic management of a patient with a vertebral compression fracture. Vertebral compression fractures are becoming common, with between 1 and 1.5 million occurring every year in the U.S. The risk of compression fractures increases with age and the decrease in bone density, so postmenopausal women have an even more elevated risk because of that more rapid decline in bone density. Osteoporosis is the leading cause of VCFs, though trauma, infection, and pathology can also contribute. To be classified as a VCF, there must be a 20% or more decrease in the anterior, middle, or posterior segment of the vertebra, which can be asymptomatic and later discovered, or it could have pain, disability, and decreased quality of life associated. X-ray is commonly used by medical professionals to discover these, although MRI is much more useful for determining the age of the fracture. The management for VCFs is commonly conservative and often includes medication to control pain, physical therapy, bed rest, and/or bracing, but there is no universally accepted method of treatment. So, chiropractic care efficacy is not very well known because it is an absolute contraindication to adjust a new fracture. So there's not much research on this, but there is some research on bracing and physical therapy, though there are some beneficial but also detrimental health effects to both of these. So there needs to be more studies on these to determine their efficacy. Some of the detrimental health effects include pain and difficulty breathing with the braces, as well as only varying degrees of pain relief with the physical therapy. This case provides an example of a female patient with an osteoporotic vertebral compression fracture and an uncommon medical history leading up to it. Treatment for this patient has included the use of NSAIDs previously, followed by chiropractic care and rehab exercises focused on regaining optimal posture and strengthening those spinal extensors. This case report demonstrates the potential benefits of chiropractic care in the management of patients with vertebral compression fractures. So when the patient came in, she was a 54-year-old Caucasian female with constant right-sided back pain. On October 13th, after lifting a case of tiles, which caused her to pretty much collapse a week before she came in. There was no history of chiropractic care, though she did have a history of seizures until she was about 13. In the summer of 2019, she was camping in the Smoky Mountains and had a severe seizure, causing her to end up in the hospital on a feeding tube for about a year. During that time, she gained about 50 pounds and lost most of her muscle tone. Before that seizure, she had been a pretty active athlete. Her psychosocial history involves extreme anxiety and depression, and she was on many medications when she presented and had quite a few comorbidities. Her average pain, she noted, was a 7 out of 10, with the worst being a 10 out of 10 when she was standing up from sitting and with quick movements. The pain was sharp, and it was in the mid to lower back and the ribs on the right. Her pain radiated all over her thoracic spine, as well as the musculature on the right side of her spine, and all of her activities of daily living were affected severely. For her physical exam, she could barely walk when she entered the office and had a really slow gait and was very tender with everything. Her vitals were relatively within normal limits, with her posture having quite a few abnormalities. Her cervical active range of motion was limited in a couple planes, though the thoracolumbar range of motion was severely limited in all planes. She couldn't even flex forward at all without the knife-like pain. In the palpation part of the exam, there was pain noted throughout the thoracic spine, with hypertonic paraspinal muscles from C7 all the way to T10 on the left. For orthoneuro testing, maximum cervical compression on the right caused pain in the lower right ribs. Cervical distraction was negative and Valsalva's was positive, with pain from T6 to T8. Full spine x-rays were taken, and it was noted that there was bone density was diminished throughout the entire spine, with a stable compression fracture at T7 and a fractured 7th rib on the right. The low back oswestry score was 68% for this patient. This was given because it more accurately defined how limited her ADLs were. Challenges to diagnostics included that the patient was more hunched forward and in a lot of pain, so it was difficult and slow going to get her set up for all the views. And the differential diagnoses were compression fracture, thoracic sprain, herniated disc, subluxation, and DDD. The initial intervention was adjustments using activator technique in all areas of the spine except for T6 to T8, with eventually using Thompson drop technique in the cervical and the pelvis. There was a 10-month care plan with re-exams performed at every 10 visits, with the initial part of the care plan being more intense, with 4 and 3 times a week, and later, in the last 20 weeks, only 1 time a week. Initial active care was gentle thoracic spinal extension exercises to try to strengthen those extensor muscles, with eventual active care to include stretches for the whole spine to improve her range of motion and her posture as well. The short-term goals were improve pain from 10 to 5 in 10 weeks, and long-term was improve her pain from 10 to 2 in 20 weeks. So when she initially presented, she had difficulty getting into the office 3 times a week due to fatigue, and she also couldn't get on or off the table without help. She had extreme anxiety, which made it really difficult with adjustments. She had to have the doctor let her know exactly what he was going to do, where he was going to be touching, and what he was going to be moving around for. On the 3rd visit, she started tolerating the drop technique in the pelvis. In the 5th, she reported having less pain and was able to get on and off the table without any assistance. On December 4th, she collapsed forward after lifting a 10-pound box that was heavier than she expected, and she regressed in her care just a little bit. On December 23rd, which was the date of her last visit, and in January, she suspended care for unknown reasons. Her first re-exam was at the end of October, and she rated her pain as a 6 out of 10, less than before. It was still sharp, but she was starting to do her activities of daily living again. And in November, her pain was down to a 4 out of 10. It was a lot less sharp. She had better range of motion, and she just stated that she was feeling a lot better. Here is a timeline. And my sources. I used 2 case reports. Both of these were discussing chiropractic management of patients with vertebral compression fractures. They both showed that either with activator or gentle manipulation adjustments, as well as stretching and extension exercises, the patients had less pain, less muscular hypertonicity within about 8 or 9 treatments. With these 2 case reports, they are weak in strength and applicability because they have limited factors that are in common with my patient. I had 2 general reviews as well, which these both discussed the management of patients with VCFs, and they talked about both the beneficial and detrimental health effects of each strategy that they talked about. And they both agreed that there is no protocol in caring for patients with VCFs, and they are about moderate in strength. The systematic review is a relatively strong article that highlighted the treatment strategies for patients with VCFs and provided a comprehensive review of literature from the past 30 years. They also conclude that there's no standard of care in place for the patients, and more studies need to be done as far as rehabilitation exercises and bracing. So as for the discussion aspect, this case report shows that intensive chiropractic care may be beneficial to people with osteoporotic vertebral compression fractures. The gentle chiropractic adjustments combined with the exercises to improve the posture and those extensor muscles provided pain relief and a higher quality of life for the patient in this case report. And by forming and utilizing an individualized care plan for the patient's needs, she experienced a lot of health benefits in a relatively short amount of time. The strengths of this case include patient compliance. She was there all of the visits that she was scheduled for, and we were able to check in on her pretty regularly to see how she was tolerating care and how it needed to be changed from there. And we also had an amicable relationship with her. The limitations involve that this is a case report, which means it has many different factors from any of the other studies that are done. And there was a limited follow-up with this patient as she only had about 2.5 months of treatment. Future studies could focus on single and multimodal approaches to caring for patients with VCFs. More studies need to be done on specifically the physical therapy, chiropractic, bracing, to see how they may help these patients. In conclusion, this case report discusses a chiropractic approach for caring for a 54-year-old female with an osteoporotic compression fracture following a seizure and a complicated medical history. The treatment plan allowed the patient to experience a decrease in pain and an improved quality of life with the ability to perform daily activities again. Chiropractic care may be an important treatment approach and should be considered for use with patients suffering from vertebral compression fractures.